also referred. We are working with UMC Victoria, IHK Hospital, and which other hospitals? Novic Hospital, Medipal, and occasionally even some of the patients have left Ruby to come. Even in Ruby ambulances, interestingly, yes. So we are proud to say that we are offering a service that I think physicians and different doctors are finding useful. The other thing that we offer is we also have a dialysis unit, and in this dialysis unit we have 4 dialysis machines which are being run. We have the neurologist that supervises everything, and we also have the dialysis technicians. I think 2 are working with us now. And we have had a couple of patients, and I think we beat the market price, even the government price. I think a session is at $350, and I don't think it's, and no one actually offers that in private practice. The other thing that we do is, I forgot to mention CT. So we don't really do MRI, we do MRI, CT, X-ray, and the ultrasound scan, but I just mentioned the MRI. But also the CTs we do both, contrast them, and then what department have I left? We have a dental department too, where we do everything, orthodontics, whitening, basically everything when it comes to that. Of course, we also run an OPD. We are tentatively an OPD, a daycare center, but we are transforming into an IP center very, very soon. What to expect this evening, I want to say, I named Dr. Mushi. I gave him a name. He treats headaches, but not for patients, for doctors. He takes away doctor's headaches. If you've had a patient, no doctor who has been in this practice does not have that patient who comes to you cannot continue, and or even you know what it is, but you've done what you can do. And it's interesting when I had just a little bit,
check inside. You'll see.
And I'm certain by the time you leave here, there will be a bit of an interesting part of it when you understand how the different interventions for management of pain, even for patients that are not able to stand enough. So it's really interesting. So I'm certain that that will be very interesting. When I leave here, the medical director will give a brief introduction to the different staff and also say something about this hospital. And then after that, after the CME, so after him, we'll have the CME, and then we'll have the remarks, and the general manager will do a closure. And no, you will introduce them. Okay, so I think that is it. I'm going to introduce the medical director, Dr. Kui Dennis, who at one point incidentally happened to be my student, is now my boss. Life is not fair. And I would like to thank you once again for coming. God bless you.
Don't worry, you're not alone.
It's not fair.
All the gentlemen here are my teachers and tutors. You're not alone. Don't worry. Good evening, everybody. Yes, Dr. Dennis Sokri is my name. And Dr. Dale here did not do justice to introduce himself. He's our senior gynecologist. He's a caretaker of our IVF and fertility department. But he always sells himself short, so I have to do the honors for him. Yes, you're welcome. At Healingware, I juggle between the administrative bit, but also I don't keep afloat of the clinical aspect of life, because as a doctor, that's our bread and butter. So I'm the medical director there, but also I head the surgery department, which we are trying to build up and to make it very vibrant. My practice is in general surgery. That's where my practice is. And I'm happy that at least we've interested some of the surgeons in this room to come and run consultations with us, and we hope it builds up. Our business model is actually kind of an open model, whereby we want to encourage all the super specialists, mostly. That's where we are trying to keep our niche. We're trying to see that we can have all the super specialties under one roof at the convenience of our patients. our theater, which is now functional, and the bit that was remaining, which was challenging from the discussions I had, was the fact that we didn't have an inpatient kind of setup. So, and most of our surgeries require either an ICU aspect or at least a patient to be monitored for a given foreseeable time. So this is being worked on, and I'm sure Dr. Nin is very happy to hear this. Yeah, this is being worked on, and we believe that in the next quarter it should be formalized. We shall also have at least 2 ICU beds, so we shall start not so simple but manageable in that setting, such that if an orthopedic surgeon wants to come and do his nailing, come and nail. If the base of skull surgeon wants to come and do his thing, he can do that. If a spine surgeon wants to come and do his thing the open way, not the way Dr. Munshi does it, you're also very welcome. Yeah. Yeah.
We can do it jointly.
Jointly, but it's okay, yeah. So, but he has talked about all our services very elaborately, so I won't dwell into that. But what I want to be very open or very clear is a healing way. We have a policy where our doors are open to all specialists. Whoever wants to work with us, we're very open-minded. And we're very mendable. For those that have worked with us, you know that we try our level best to make our specialists comfortable in ways that we can. So personally, as I try to build up a vibrant surgery department, I look forward to working with you in this aspect. And since most of you are my mentors and tutors, you'll teach me a thing or two in that regard. So without further ado, our speaker today must be known to many. He's been in this field for over a decade. He's a pioneer of a specialized form of pain management in the East African setting and beyond. He's an Indian. He has his own practice still in India, in Gujarati. We'll talk more about that. I won't preempt it. Dr. Munshi here is bringing this, because when we interacted with him, I was like, Dr. Munshi, you've been doing this for a very long time in Kenya, and the Kenyans have benefited. Why not Ugandans? We do have our specialists who are actually quite gifted, and I'm very sure they would be very interested in this particular field that you've built up over the years. So without preempting him and pretending to know what he does, I'll allow him to come and give us a talk. Thank you so much. Thank you for your time.
Thank you, Dr. Dennis and Amal, for inviting me, and thank you everyone for coming here. So now, so basically, we are one of the pioneers for some advanced technology, particularly for the interventions in the spine. So like, I have been working in Kenya for the last 14 years. I have been visiting every month, and like we have quite sizable work over there. Sometimes I open 40 to 50 patients in only one visit. So that is anyway one of the biggest number. And over the period of time, we have developed a technique from intervention to the transfer endoscopy to the internal endoscopy to the fusion. So next. So I have divided the topic into the spinal pain, and then the joint issues, and the neuropathic pain. So let us first speak about the spinal pain. So now you know what so what happens currently, like every orthopedic surgeon or every neurosurgeon, half of the OPD is full of the chronic pain patient. And the moment like we hear back pain, it doesn't go down, so it's like a kind of muscular pain or whatever. Then we just keep on prescribing the medication. But now we have come to a stage where now we can pinpoint that okay, in the back which can be the pain generator. Like we talk about the pain generator, like it can be the disc, it can be the facet, it can be the bone, it can be the muscle, or it can be the nerve. So these are the 5 pain generators can be present, and out of that we have to identify that which pain generator is the reason for the patient's pain, and then we can treat it. So like up till now it was like the chronic pain is not treatable and the patient has to manage for the rest of their life. But no, it's manageable. We do have the option, and now in the option we have now more different options. Like suppose even if you want to do the discectomy, so we have the percutaneous instruments to like a striker decompressor or something. So you can just pull out the disc. Then you have the transfemoral endoscopy, so you can just put inside and you can take out the disc and the vessel. There are some issues with the transfemoral endoscopy, so right now we are doing the interluminal endoscopy, so you can do the discectomy as well as the posterior decompression also. And in interluminal endoscopy, there are some certain other aspects, and there are specific indication for the patient when they have the instability. So in instability, you need to fix the instability. So we have the percutaneous fusion also. So I'll just try to give the overview about each and every technique. Next. So now you see the most important aspect in the spinal pain is the diagnosis. That most of the time we are not sure, and it has been proven that we decide the patient depending upon the clinical examination, depending upon the patient's presentation, and we have the radiological modality in form of X-ray, CT, MRI, ultrasound. But none of this investigation is going to tell you about the pain, because the pain is a kind of symptoms which is mediated by the cytokines, and these cytokines are not seen on the any radiological investigation. So in more than 40-50% of the patient, the presentation of the patient and the clinical and the MRI finding will be different, and here we are confused about what to do. So I'll just take few slides about the basic of the spine anatomy. So in anatomy wise, we divide the spinal column into the 3 parts: anterior, middle, and posterior. So anterior is the disc, middle is the spinal canal, and the posterior is the lamina of the structure. Next. So now next. So now the most important aspect of the pain is the disc is having the dual nerve supply. So the disc is mediated by the somatic nerve as well as by the sympathetic nerve. And these sympathetic nerves, they don't follow the rheumatoid distribution. So if the sympathetic system is involved, then the patient will not have the classical radiating pain or something. The pain will be very, very different. And they, like especially the young patient, they will come with so many different kind of presentation. Like they say that I have with the pain, I have the urinary urgency or something. So then this all the sympathetic nerve is not like the somatic nerves, that they are the dermatome-wise distributed, and you exactly know that okay, this dermatome is being pinched, and you know that what to do. And the most important part is like the disc is only innervated in the outer one-third. So what happens whenever there is a disc pressure? So like when there is an increase in the interdiscal pressure, so the outer part annulus will not be able to hold the nucleus. So what will happen? It will give away. So this fibers, the annulus fiber will give away, and it will start having an annular tear, and this annular tear will keep on extending. But only the outer 1/3 part of the disc is innervated. So when the patient is having the first time symptoms, it means almost 2/3 of the disc is already been, or 2/3 of the annulus is already been breached. So now it means that this presentation for the patient is acute for that particular day, but it has a long roots back, that it starts before something happens, and then it ends here. So now because of the dual nerve supply, what happens is the patient will have the very different presentation in the symptoms. So like the similar patient with the similar disc herniation, but two patients will have the different presentation, and sometimes we are confused. Next. So here the sympathetic now is and you can see the dorsolateral ganglia here. So you can see this sinovertebral now. So this sinovertebral now has the intervention of the posterior part of the annulus, and that is something is responsible for patients' different symptoms. Next. So now you see this intervertebral foramen is the area where the nerve roots are coming out. So the disc is in the 360 degrees, but only the posterior 1/3 part is only when the disc herniates out, it becomes symptomatic. And especially this foramen area is something, even the smallest herniation or smallest chemical leak of the cytokines, the patient will have the very severe symptoms. So like you see the big disc and the patient say, I'm okay, I can do everything. Sometimes I walk for long distance, I feel pain. And you see that normal looking MRI and the patient is having the very severe symptoms. So this is induced by the cytokine leak because the disc is containing the cytokines. Next. So this cytokine now it has been identified as a proteoglycans A2. So this proteoglycans A2, the content of the proteoglycans A2 is 10,000 times more in the disc as compared to the blood. And this is a very severe irritative inflammatory mediator. And when it leaks out, it produces the intense inflammation, and that is the reason the patient will have the very severe acute pain. And then once the acute pain subsides, then you can see that even the disc herniation is not too much, but still the patient's symptoms are more. So basically, by doing the medication, so almost we are using all the anti-inflammatory medication, anti-inflammatory medication in form of NSAIDs or in the form of steroids or injectable steroid or maybe the root injection or something. So actually, we are reducing the inflammation. So when you reduce the inflammation, then the patient's symptoms will go down. So the pain is mediated by the cytokines, and the pain is possible only because of two reasons. One is the inflammation and one is the distension. So here in this herniation, the both mechanism, you see, in the body there is no possible pain without having inflammation. We cannot give any single example. And the second is a distension. So here the disc stretch out, so there is a distension also, and because of the inflammation, the patient is having pain. So whatever the medical management or the conservative management what we are doing, so actually we are trying to buy the time. So the inflammation itself will subside, and we take the control of the pain by giving them the painkiller or rest or something, so that this inflammatory leak, cytokines leak, will stop, and then gradually the disc will heal. But in my experience, like if you find the patient who are having the good sizable problem, and if you treat those patients conservatively, invariably this cascade of inflammation from the acute inflammation will go into the chronic inflammation, and it will induce all the changes into the spinal canal in form of everything, like epitophy, hypertrophy, fascial hypertrophy, and ultimately those patients, now you see that most of the patients, if you come with the spinal stenosis, so the difference between the spinal stenosis and the acute herniation is, in acute disc herniation there will be a radiculopathy, so the patient will have the classical dermatological pain radiation, while the SLR will be positive, while in spinal stenosis the patients are only symptomatic while they are standing and in walking. So there are two mechanisms which, so usually the stenosis patient, they don't have pain. They will just come with a complaint of the numbness or heaviness or maybe weakness. So there are two possible mechanisms in spinal stenosis. One is the area of the spinal canal, because of all this chronic inflammation, because of the aging, because of the subsidence of the disc height is going down, so this area become narrow. So now instead of you are having the big spinal canal, you have a little narrow spinal canal. So that is, we call it a fixed stenosis. And there is one more component of stenosis, is a dynamic stenosis. So whenever the patient stand or they walk, the gravity assisted, they have the blood flow going to the spinal cord. So there are small veins. So they have a venous congestion. In this venous congestion, the vein will dilate. So they will produce a further narrowing of the narrow-spinal canal. So this will lead to the, so like you see, all these patients with the stenosis, they will come to you, they say, I'm fine in sitting, I'm fine in lying down. Moment I stand for some distance, stand for some time, or walk for some distance, I start getting pain. Then I sit for some time, I become comfortable, because when they sit, this venous congestion relieves. So this dynamic component of stenosis, it goes away, and then you have the same kind of spinal canal. So like the symptoms goes away. So basically, in acute disc herniation, the pain is mainly mediated by the cytokines, and if we do anything to reduce the inflammation, the pain will subside. But suppose if you find that the disc herniation is big and it's likely to create a mechanical compression or something, then it's always better to become more aggressive here, because the nervous tissue, when they get the compression, so they might have some irreversible nerve damage which can happen, and then even if you operate, you don't get the same result. So if you have the radiologically proven big herniation, my suggestion is not to wait for those people. So now this is one of my favorite slides. So like I decide the patient that okay, this patient comes to me. So if patient is having the symptoms of the nerve irritation by the chemical inflammation in form of pain, numbness, so then I will think about doing the intervention by doing the either epidural injection or maybe the disc injection. So that will reduce the inflammation, and once it's reduced the inflammation, it will help disc to recover faster, because the persistence of the inflammation is the reason for the persistence of the pain. So if you reduce the inflammation, there are good chances the disc will heal, and once the disc will heal, so those patients will have very good relief, and they may have the long-lasting relief or may have the permanent relief also. So when you have the patient who are having the chemical inflammation, so whatever the kind of pain the patient is having, the more pain is because of the more inflammation. So if you can do something to take care of the inflammation, you don't need to do any surgery. And if you have the pressure, so like the patient will come from with the heaviness or the weakness. So in that case, there is no other option. This compression has to be relieved by whatever the way you are comfortable. So maybe for endoscopy or maybe open or whatever the way we can do this. Next. So I'm not going to the detail about the disc herniation. Next. So now the disc can produce the two kind of symptoms. So one is a discogenic pain. So discogenic pain is basically there is a small annular tear in which the disc fragment is resting inside, and whenever they are sitting, so like disc is having the dynamic pressure in the different position. So like when you lie down, the pressure is different. When you turn on the one side, the pressure is different. When you stand, the pressure is different. So the maximum pressure is there when you sit or when you bend. So when this happens, it actually stretches the disc, and it produces the further irritation of the annulus. And this disc fragment will sit inside the annulus, and that is the reason. So we will see on the MRI HIZ. So this HIZ is a disc fragment sitting in the annulus, and those patients will have like they don't get relief, and they just have one symptom, is sitting intolerance. So they are not able to sit for long. And whatever the management you do for those patients, it's not going to work. And mostly we don't accept those patients also because they don't have a radiculopathy. They have only one complaint. So sitting long, they are not comfortable, and they have like a classical, if the patient is having the alpha S1 disc herniation, so the last welcome disc, the pain pattern will be like this. And if it is a second last L45, the pain pattern will be like this. So even some of the patients, they will have this pain up to the thoracic area. So actually this is a referred pain coming from the L45, and the L5S1 pain is like the pattern is like this. So like this is like a very simple question. If you ask the patient, you can have your clinical diagnosis even before you see the MRI. So even I decide upon my intervention also depend upon what is the patient's complaint. So like the pain is like this or like this, the patient is pain like this, I will after they touch the L5S1 disc or the last disc first. So for the discogenic pain patient, we have to confirm. So usually on the MRI, next. So usually on the MRI you will find the HIG hotspot, and sometime still in the majority part of the world, the patient just has the pain, and you will just either see HIG or the black disc on the MRI. But there is no radiation, nothing, and patient will have only one complaint. So most of the time they have been referred to the physiotherapist for 2 years, 3 years, 5 years. They keep on doing. So even it's very difficult to convince the patient that no, you have a disc problem. Then he will say, I have seen 10 different doctors, the top doctors, and even I went to out of the country, and I have seen those patients, those specialists. But nobody told me like this. So in those patients, you have to confirm. And you have to convince the patient by doing something which the patient will convince. So we do like a provocative discogram. So in which we put the disc needle inside, and then we pressurize the disc, and with the pressure. So we are actually mimicking the situation where the patient is sitting and there is increase in the interdiscal pressure. Similar way, when we are injecting inside, it will increase the disc pressure. So patient will have the same kind of provocation. Next. So. Okay, now this is one very important sign. See, all the tests what we are doing is a subjective test, and we don't know that because we do the SLR. So the SLR doesn't give you the very specific idea about the particular dermatome. So even patient will not complain you, but because of this the disc condition, because of the inflammation, the nerves in the peripheral part it becomes tender. So if you palpate the sural nerve, if you palpate the sinus tarsi, the patient will having very severe pain. They will jump out of when you touch the nerve. So this tenderness of the nerve. So even for the cervical C5, 6, everything, if you just touch the anatomy box here, and if you just press it, so even this will immediately give you the idea that this nerve is tender, and even the patient doesn't give you any idea that I have a radicular pain or I have a foot pain or something. So this tenderness of a nerve is a very specific sign that this pain of the patient is because of the disc herniation and because of the inflammation. And even if you inject a local anesthesia on the nerve, entire radicular pain goes away. And even majority of the patient when they have the acute disc herniation, they are not even able to lie down for the MRI also. So if you just do this crystal block, we call it a crystal block, and if you just immediately relieve the pain, and you can do the MRI. So even sometime when I take the patient for the position, because I do most of endoscopy under local anesthesia, the patient are not able to lie down. So I just do the distal block first. So even this is very good to confirm your diagnosis. Even post-operative, even if you have done the open surgery and if the patient is having the radicular pain, if you do this is something I can say it's a game changer in the management of the spinal pain, because the moment you numb the nerve, so it's not like that local anesthesia will work for 30 minutes or 2 hours and then pain will come back. It's not a simple mechanism. We call it a peripheral sensitization. So this peripheral sensitization will start the impulses from the nerve. So the nerve itself will become the pain generator. So even after the stimulus becomes stopped, still the nerve will act as a pain generator and keep sending the signals, and that will give you the same kind of pain. So like see, we all have the understanding that we operate those patients, and like post-operatively, like we say, you have to wait for 1 month, 2 months, 3 months. But you try this thing in your practice, and you will see the wonders. And even like when you are not certain about the diagnosis, just touch the patient, do the palpation, and inject with just 2% lignocaine, 2 to 3 in there. It will just change the entire spectrum, and patient will also be and you will also be confident. No, my patient is excellent. So this is called the Gore sign. So this is about the discography. So like you can see, this is a normal disc, and this is the content disc. So you can see there is the annulus is break, but it's inside. So you can see there is a small annular tear but the contrast will not leak out.
Yes, it's there.
So this is we call it the IDD, internal disc disruption, and you can see this is a completely torn disc. So discography is actually a more advanced way to diagnose and to confirm the disc is a source of pain than anything else. Next. So now you see when we have the patient who are having the inflammation and they are having pain, so we do just inject the anti-inflammatory medication exactly at the site of the area where there is the inflammation. So you have to go to the area where the disc is in touch with the nerve. So we do the couple of procedures here. Next. So this is the chart about the radicular symptoms. So depending upon that, you can decide at which nerve you want to target. So usually there is always a traversing root pathology, except you have the foraminal pathology, and you have the exiting root pathology. Next. Next. So like you see, normally like people used to do the interlaminar injection. So like in interlaminar, they go from the midline like this. The anesthetist they usually do it. But here the pathology is on the anterior and the lateral part. So when you inject the medicine inside, the medicine will go to the posterior part. It will not reach to the already at the area where there is a stenosis and where there is a pathology. So instead of this interlaminar or translaminar injection, next we prefer to do the root block here. So like we do something here. So this is exactly the area where there is inflammation. Not here because it takes like a lot of effort from traveling the drug from here to the interlateral part of the abdominal space. Next. So like you can see, this is like one of the very simple procedure under the X-ray guidance. You can just go. You can depend upon the nerve you want to target. So like this is going to take care about the exiting route, the traversing route here. So like in that case, you have to go to this cambium triangle, and you remain there. So when you inject the contrast is going to give you the exact idea that you are able to see the nerve, you are able to see that you are not inside the spinal cord or something, and the third thing, you are not into the vascular space also. So being in a vascular space and injecting the drug, it can lead to a major complication. So that's what injecting contrast is always going to confirm. Next. Okay, so now we talk about the simple patient who are just having the pain. They don't have the weakness or they don't have like a kind of a paraplegia or something. So now we have to have the definitive management for those patients who are having the big disc condition or the major spinal cord compression. So in which apart from doing the routine open surgery, microscopic surgery, tubular surgery, now we are doing more of a endoscopic surgery. Next. Next. Okay. Next. So this is I already spoke about it. Like you see this patient, I already did one level, so now I was a little confused. So on table, I am doing the second level discography to confirm that this patient is having pain or not. So you can see that I'm putting the needle and then we see that if I see the contrast is leaking, so then it means that I have to operate. Now you see it's leaking out. Now you can see the PLL is little elevated. So like this is since we are doing the local anesthesia and this is the evidence what you have, so you are very sure that you are operating on the right disc. Otherwise, if you see the literature, if you see the first complication of the spine surgery is the wrong level. Second complication is the wrong level. Third is also wrong. So like that is so common because you feel this look like a problem, you operate it and the patient says, I don't have any relief. And then you realize, oh my god, this was a sacralization or the lumbrization if you operate from the wrong disc. So it's always better that when you have the patient, you do a discogram, you confirm and then you finalize. Next. Next. Okay, so like if the discograph is positive, then depend upon the pathology, we do either the intervention or we do the endoscopy. So like the similar way, like I tell you that you must have so many patients who are having the interscapular pain or the thoracic pain. basically, and I have seen the people doing the thoracic MRI and they are trying everything and nothing is working for them. So actually those are the patients who are having this is a deferred pain. So even the cervical pain can go down up to the angle of the scapula also. So like, and these are the big number of patients because they have the small annular tear and this annular tear is not letting this fragment to go out or go in. So it stays there and it keep on producing the problem. So now you see, now from the transfemoral injection also, now we have gone a little one step ahead also. That now we are doing more of an intradiscal injection. So this intradiscal injection, once you go inside the disc, so it's going to take the same path of inflammation from where the inflammation started. So like when you inject the medication, so this medication will remain inside the disc and it will leak through the annular tear, and it will reach to the PLL, and it will reach to the epidural space and to the root. So you are catering the entire path of inflammation which is being there. So like normally people say that the root block only works for radicular pain, the back pain doesn't have relief. But if you do this, then even the back pain also goes away. So, and this is also one of the very, very effective way because you are taking care of the complete inflammation and even the source of inflammation. Picture, so like you see, this is for the cervical. Like if we always go contralateral side. For the right side symptom, we go from the left side. From the left side, we go from the right side. And you can see, you can just do this and confirm, and then you can just inject maybe 1 to 2 ml of medication. And I tell you, this is something the most effective way. Like this is one of my favorite procedure that you just go inside and you just do it with a simple spinal needle. So like you don't need a big gadget or something. And all the other intradiscal procedure, percutaneous procedure, I say that this is more effective than doing anything bigger. And now, when the patient is having only radiculopathy, so then in the radiculopathy patient, so in that patient, like the patient doesn't have a discogenic pain. So like, so in that case also we do the contralateral side. We go from the, so this is we do it from the back. So we go from the left to right or right to left. We see on the X-ray, live X-ray, and we see that the nerve should be able to visualize. So whatever nerve you are targeting, you should be able to visualize those nerves. And I always pack a catheter here. So the catheter will give me the scope to inject the medication with the pressure. So even this will open up the small adhesions between the dura and the ligamental stemum. And you know, next. And you know the next. Yeah. So even in those patients, they will immediately feel even the motor improvement also. So you will feel your hand is more strong. So this is almost 10-year-old. I did this patient in Isolate. That's the difference. That they feel immediately improvement in the power, the movement, they become very. So you see. I hope we will see those problems here. So now you see. So now you see, this is the main thing here. The patient will not complain to you about something like say like if you do the root block or if you do the endoscopy, that patient will say, yeah, doc, I can see my foot is now freely moving, which was not there. So like when you use the local anesthesia and you just use the sensory dose of the local anesthesia, it will just inhibit the pain sensation. So just because of the pain, there are so many other symptoms which are there which you don't realize. And even after doing this, the patient will say, I have a pain like this, but you do the injection, it is done perfectly. Then after the procedure, patient will say, doc, I can see my toe is moving freely. I can see my ankle is now very free. So these are the changes also, which even the patient, because of the chronic status of the disc condition or the nerve, they even don't know this is normal. So that all you can see. And especially when you have the awake patient, when you take care of the patient's pain, you can see that big difference. No, wait. So now, if there is a mechanical compression, so if I have a patient with a radiculopathy and the disc is a problem, then I do the transfemoral endoscopy. if the patient is having claudication and the posterior segment stenosis, then I do the interlaminar endoscopy. Next. So like this transfemoral endoscopy. So like both endoscopy I do completely under local anesthesia. Next. So you see this gentleman was like he was referred by a very senior orthopedic doctor and he was uncle to him. So he was having the pain here, very severe pain. There was no other symptom. So he called me and said that this patient is having piriformis syndrome. So you do for the piriformis syndrome. So I examined and I said, so this piriformis is a reflex spasm because of the nerve irritation. So let me do the discography. If it is positive, I will do the endoscopy. And then so you can see. So from the side, you can go to the intervertebral foramen inside the disc, and you can see the things here. So you see you can see the entire anatomy very clear, and I can tell the patient to move the leg. This is the most beauty. You are not worried about anything. Even I don't catheterize my patient. The patients are completely awake, and like I can take all the medical comorbid, complicated patient said by anesthetists or the physician, no, you cannot give the GE to this patient, or the patient is not fit for the surgery. So even now, the age is not even the limit for us. We are putting 90, 95 years old patient also. And at least we can give them a quality of life. And you can see these are the disc bulges we already have removed. Next. So now you see it. And now because of the advancement in the optics and the instrument and everything, so you can see this beautiful picture. So you can see the dura, you can see the ligamentum flavum, and you can see how nicely you can just decompress it. So we have developed a technique. So like I can say that I started doing interlaminar endoscopic surgery under local anesthesia. So you can see the endoscope, you can see the indication going on, and you can see the patient. So like this patient, this patient is having myasthenia gravis. So like he was contraindicated by everyone to go for the surgery. I say no problem, I can do it under local. So you see, this is how we do the docking on the X-ray. So like we mark and we put the endoscope, and then we just do the decompression. So these are the special instruments and the endoscope. We will use this. So even the cervical endoscopy, so we do have the option for the anterior cervical discectomy and posterior cervical discectomy. Now you see, this is just recently is so even you can see that the cut is even smaller than my little finger. And you can see everything on the vision, very classic. And so even for the instability patient, we are also doing the endoscopic excision also. Like we can put the
Doctor, the same saying, more attendance. Yeah, just for calling.
that is also like this is under epidural anesthesia. So like the patients are awake. So like this is also like one of the very simple things. Because you just have to go transpedicular and then you put the screw, and then you connect with the rod. So this is like this patient will have the scar like this. So there is no open. The cage we put from the side. So the endoscope discectomy and the end plate preparation we do with the transfemoral way. And this is the 4 screw. So next, so like you can see that this is we have done with this small cut. So even we are regularly doing all this fixation under epidural anesthesia. Like my idea is not to give anesthesia to the patient. Is you can avoid as much as possible. Next. Okay. Now, so I finished the spine. Now we have 4 or 5 more slides. So like this is about the vertebral fracture. So for the vertebral fracture we do the percutaneous augmentation by doing the cementing. So like this is also local under local anesthesia. So like see, why local anesthesia? Local anesthesia because you can prevent so many complications related to the anesthesia, and even after your see for me the most important is the patient feedback, because we all believe the awake patient is your best neurological monitor. Patient can give you directly feedback. You are not worried. Otherwise, you see, I tell you, every surgeon after finishing the surgery, they are just worried about one thing: the toe movement. So the patient and see like even like they don't go home or they don't have relax unless they see the patient moving. So you see that this is how we do this. So this is we are putting the balloon, and then you can see that you can get the saline. So this is like also one of the very rewarding procedure where the patient is having a very serious pain. They are like almost like they are not even able to turn also. Change of position is the hallmark of the vertebral fracture. They are comfortable in one position, then if you want to change it, so like if you do like this, if you want to sit, they will sit. But change from the sitting to or turning or something, so the change of position will become very painful. And by just injecting the cement, you can just anchor all the free fragments, and this liquid cement will immediately become the solid, and the patient can walk from the table also, because within 10 minutes the cement get fixed. And now for the early osteoarthritis, we are doing the fluorotherapy in terms of either PRP or stem cells. So like if the patient who are having early stage 1 or stage 2 arthritis, we can always take the patient blood, remove the blood cells, and they inject inside. So this will reduce the inflammation, and then this will reduce the healing. So like only like we are just assisting the healing process, which is happening naturally. So definitely the stage 4 arthritis will develop from 0, 1, 2, 3. So we catch those patients at the stage 1, 2, and some patient of stage 3, even they can be managed with PRP instead. And for neuralgias, so like any nerve irritation which is giving you the severe pain, we can do the selective nerve ablation, like the trigeminal neuralgia. Next. So like you see that this is one of the most severe painful condition known to the medical science. The patients are like just like they are just dying, and after certain time, no amount of medication is going to work for them. If you increase the dose, the patient will get more disease. That's so like even we have done over 5,000 trigeminal radiography, and this is like a 15-20 minute procedure. You need a special machine, and you can just ablate selectively those nerves. And with this machine, you have the option to do the sensory and the motor stimulation also. So you are very sure that you are very close to the nerve, and then once you finish it, the patients are like the most happy patient. Otherwise, this is the cases where sometimes I have to do in the middle of night, because the patient will traveling from far and say, "Doc, I cannot pass this night without do something." I say, "Okay, let's go tonight only." So usually these are the very elderly patients. Yes. And now we have the very advanced procedure like a spinal cord stimulator. So like those who are having the phantom pain, or those who are having the entrapment neuropathy, those who are having the epidural fibrosis. So in those patients, even the herpetic neuralgia. So we put this implant. So like we put this electrode on the nerve, and this electrode is connected to the pacemaker. So these are the same company who are manufacturing the heart pacemaker devices. So this is also we do very regularly, and believe me, there are certain group of patients when they need this thing, you have to do this. There is no other option will work for this patient. And these are the US FDA approved devices. These are from Medtronic, these are from St. Jude, and some other companies. So there are hardly 3-4 companies in the world who are manufacturing this. These are very expensive, but you see, like when you have the option, then you can provide this option to the patient. Next. And the last is the intrathecal drug delivery system. Next. So like you see here, terminally ill cancer patients. So they have a very severe pain, and they know that they have a cancer, they are going to die, but they tell you, "Doc, do something that I can die peacefully." So here you don't have much option to give the NSAID. So here the advantage of when you give the drug intrathecally, so the dose requirement becomes 300 times less. So suppose if patient is in need of 300 milligram of morphine, if I inject intrathecally, they just need 1 milligram. So naturally, if you increase the dose, side effects are more. But if you put it this intrathecally, and second is like this is so advanced, like even like we have now wireless charger, but we are using this almost 20 years, since 20 years. So this is having the wireless charger. You get the remote, so like you set up the dose, and then you have the option to have the bolus dose. So if you want to take the bolus, you just have to press the button. So we do all the programming to the patient. So like this is for controlling the breakthrough pain, and when the pain is out of the barrier. So like and since this is going to release the drug in a very continuous manner, so there are no ups and downs with the oral medication or injectable medication. So like this is also one of the very good device, and especially for the spasticity patient also. Like those who are having the both of the spasticity, or maybe the kids who are having too much in the spine. So we cannot give the baclofen dose to certain extent. But when you have this option,